Medical management of thyroid eye disease involves the use of drops, tablets, and intravenous drips. If, after your initial consultation, your diagnosis is for medical management, the doctor will prescribe either tablets or drops, and a return appointment will be made to assess their effectiveness.
For the patients who have mild disease, all they require are generally lubricants, and I generally recommend that those lubricants are preservative-free, because if the drops are being used frequently, then you can get into a problem with preservative toxicity. Patients who have a little bit more swelling particularly of the white of the eye, the chemosis, will benefit from antihistamines and non-steroidal anti-inflammatory drugs such as Froben in combination with the lubricant drops. But when we move on to patients whose disease is more severe, then we were probably talking about starting systemic steroids, which are really the mainstay of treatment.
Steroids is the most effective treatment for thyroid eye disease, and that's been shown in studies. Oral steroids work within a few days, 2, 3, 4 days, certainly within a week or so. And what we normally do when we give steroids orally is that we'll review them in 1 to 2 weeks' time, and by then you should have a response to treatment. So the patient should feel that they've improved, and we should be able to measure their improvement as well.
Well, the first thing we need to establish is whether the condition is reversible. And generally I would prescribe a trial of high-dose steroids to see if the condition reverses. I would see the patient at a week and see if the patient has noticed subjective changes, and particularly if I can measure objective changes in terms of how far the eyes are coming forward or how wide the lids are open, and what the surface is like on the eyes, and if there has been any optic neuropathy, whether that has improved as well. And if the trial of high-dose steroids has been successful, then I will either continue on steroid at a lower dose, or offer one of the other immunosuppressants such as cyclosporin or tacrolimus.
If you are prescribed drops, or either steroidal or non-steroidal tablets, you can take these away and self-administer the treatment at home. But it is vitally important you take the medicine as prescribed and complete the full course given to you. Should your consultant, with your consent, decide giving you intravenous steroids using a drip would be the best course of treatment, the hospital will arrange for you to be admitted as an outpatient once a week for 3 or 4 weeks.
Intravenous steroids works even more quickly, and sometimes you get a response in 1 or 2 days. And again, you'll see that the patient will feel they've improved, and also in some cases you can see that their parameters changing, such as their vision improving or less swelling. In terms of duration of steroid treatment, initially everyone would get at least a 6-week treatment course, whether that be oral steroids or intravenous steroids. Following that, you then titrate it against the patient's response. So typically patients may be on a lower dose steroid for 3 months and occasionally up to 6 months with a very low dose. But with a higher dose, it's usually only for about 2 months, 6 weeks to 2 months, and then you taper off the dose within 3 months, but occasionally it's 6 months.
Non-steroidal and steroidal treatments are usually given while your thyroid eye disease is in the active stage. Unless there is an urgent need, your consultant will wait until the disease has become dormant to assess whether subsequent surgery is required.
Sometimes the improvement with the immunosuppression is sufficient so that no surgery is necessary, or sometimes just a minor lid correction rather than anything else. This is the whole point of using the immunosuppression early, is to minimise what needs to be done at the end of the day.
For the vast majority of patients, there are few or no side effects from steroidal treatment. But it is important to be aware of possible problems with the use of both intravenous and oral steroids.
So the side effects are related to the length of steroid use and the dose of steroid use. And we tend to use a high dose initially and then reduce it quite quickly. The most common side effects of steroids initially is it can give you sleep disturbance, mood changes, it can make you low or it can make you high. The other changes can be that it can change your blood pressure and can cause high blood pressure, especially if you're prone to it. Similarly, it can induce diabetes or sugar in your urine, and again, if you're prone to that as well. Other side effects include increased risk of getting infection, which is fairly unusual but possible, as well as weight gain, and also change in fat distribution around the body. So some people get fatter around the face as well as generally increasing weight as well.
I also have to advise patients who are on these drugs that there is a long-term risk of malignancy of the of white cells called lymphoma. The risk is small, and that there is a lot of data available because these drugs have been used for quite a while in patients who are on kidney transplant. So there is a lot of data available. And the risk appears to be around 1 in 10,000 to 1 in 1,000 of lymphoma. But that data comes from long-term use. There is also a risk of skin cancer, which is particularly squamous cell carcinoma. And so I advise patients to use a high factor sun cream on all exposed areas, to not use sunbeds, and to also make sure that somebody checks their back, because obviously you can monitor your own front surfaces but not the back. So that's very important. It's also important to advise that if a patient is on the oral contraceptive pill, for example, that may not be fully effective and a barrier method should be used. There have been pregnancies on tacrolimus without any particular problem, but in general it's a good idea to avoid pregnancy for the duration of the immunosuppression treatment.
One of the other common side effects with long-term steroids is thinning of the bone, because steroids change the metabolism of how the bone is metabolized. But that's why we tend to give drugs to counter that as well. In terms of intravenous steroids, the side effects tend to be a little less in terms of long-term, but they have to be administered very carefully, and we administer intravenous steroids, so that's steroids in the vein, in hospital. So what would happen is that you'd come in, you'd stay a minimum at your first visit for about 4 hours, where certain checks are done, such as blood pressure and urine to check for sugar. Then you have to have a little cannula in your vein, and a drip is set up where the steroid is given over a period of about 1 hour. And then we monitor things like blood pressure for a few hours to make sure it hasn't changed acutely. And if all is well, then you can go. And then on subsequent treatments with the intravenous steroids, you stay here a little bit less time. And the intravenous steroids can either be given roughly weekly. So we tend to give it weekly for about 6 weeks, although some patients will get 2 doses, depending on the severity, in the first week. We tell patients not to stop their steroids suddenly, especially the longer you've been on it, your body gets used to it and you produce your own steroids and it affects the balance. Therefore, if you suddenly stop the steroids and the balance goes out of kilter, then you might become unwell. So we tend to taper off steroids. So you might start at 80 milligrams, then you go down to 70, 60, 50, 40, and that's done over a period of weeks. So you should never stop steroids without discussing it with your GP or the clinician who's treating you. So it's important that before you stop steroids, it's discussed, and normally we reduce the dose over a period of weeks. Generally speaking, success for treating patients can range anything from 50% to about 80%, and studies have shown that, especially with steroids, oral steroids and intravenous steroids. And that tends to mean that half to 3/4 of patients will improve with treatment. That is slightly confounded by the fact that some patients would improve anyway, even if they didn't have treatment. But most patients do improve with treatment, and a small group of patients who don't improve with treatment then go on to have a different form of treatment that may be more aggressive treatment.